faculty members and participants who have joined from various parts of India and abroad. And good morning to our guest speaker for today. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Maury Gertz, all discussants and participants to this virtual symposium on Waldenstrom Macroglobulinemia and update. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a humble, well-respected senior hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Maury Gertz from Mayo Clinic, Rochester, USA, and he's going to lecture us on Waldenstrom Macroglobulinemia and update. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Maury Gertz from Rochester, Minnesota, USA. All our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing a Saturday evening, morning, and afternoon from whichever part of the world you logged in. Tomorrow, that is Sunday, 9th of June, 2024, from 11:30 a.m. Indian Standard Time, we have Surgeon Commander Dr. V.A. Arun from INHS Ashwini, Mumbai, speaking to us on multiple myeloma, choosing treatment regimens widely in our country. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Ankita Sen from Chittaranjan National Cancer Institute, Kolkata. Surgeon Commander Dr. V.A. Arun from INHS Ashwini, Kolaba, Mumbai. Dr. Bilal Kazi from Apollo Multi-Speciality Hospital, Kolkata. Dr. Ekta Jajodia from Unipeth Specialty Lab, Ahmedabad. Dr. Girish Badarke from HCG Manavta Cancer Center, Nasik. Group Captain Dr. Arshit Khurana from Armed Force Medical College, Pune. Dr. Neemya Thanda from North Okalappa General Hospital, Myanmar. Dr. Jeevan Kumar Garg from Tata Medical Center, Kolkata. Dr. Madhura Tenaikar Deshpande from Bharati Vidyapit Medical College and Hospital, Pune. Dr. Manu Vimlachandra from University of Colombo, Sri Lanka. Dr. Myat Malleshwe from University of Medicine, Medley, Myanmar. Dr. Pujita Bai Reddy from CARE Hospitals, Hyderabad. Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad. Lieutenant Colonel Dr. Ranjit Matthew Varghese from Command Hospital, Pune. Dr. Samir Malinkuri from Dinanath Mangeshkar Hospital, Pune. Dr. Sandeep Partake from Bharati Vidyapit Medical College, Pune. Dr. Sanyo P. D'Souza from KMC Hospitals, Mangaluru. Dr. Shailendra Prasad Verma from King's George Medical University, Lucknow. Dr. Siddesh Kalantri from Blood Care Hematology Clinic, Nasik. Dr. Themodika P. Vithanage from Base Hospital, Panadura, Sri Lanka. Dr. D. E. Montan from North Okalappa General and Teaching Hospital, Yangon, Myanmar. Dr. Yogalakshmi Sivaprakasam from Star Hospitals, Hyderabad. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Maury Gertz from Mayo Clinic, Rochester, USA. Dr. Maury is professor at Division of Hematology at Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota, USA. He is also Chair Emeritus, Department of Medicine, Roland Sidler, Junior Professor of the Art of Medicine, Mayo Distinguished Clinician, Master American College of Physicians. He is also the member, Committee on Training, American Society of Hematology from 2015 till present, member, Hematology Board Exam Committee, American Board of Internal Medicine from 2015 till present, Waldenstrom Award for Medical and Scientific Achievements in Waldenstrom Macroglobulinemia 2014. He is a Treasurer, International Myeloma Society from 2011 from 2014, Mayo Clinic Roland Schindler Junior Professor of the Art of Medicine, honoring Dr. Michael Brennan 2010. President, Mayo Clinic Officers and Counselors, Mayo Clinic 2005, 2020 till present chair, longitudinal knowledge assessment at Hematology Approval Committee's American Board of Internal Medicine. He's also the member Committee on Training, American Society of Hematology, 2015 till present, Hematology Approval Committee, Hematology American Board of Internal Medicine, 2021 till present. Also the member, Hematology Board Exam Committee at American Board of Internal Medicine, 2015 till present. Also the chair of American Board of Internal Medicine. And today he's with us and he's going to lecture us on Waldenstrom Macroglobulinemia and update. Well, thank you so much. Over to you, Professor Dr. Maury Eggerts.
Thank you, Dr. Khurana, and thank you, Dr. Agarwal, and my thanks to Mr. Madden for arranging this. Let me share my screen and we will get started. There we go. So we'll just start with talking about Waldenstrom's macroglobulinemia. And these are my disclosures, and the learning objectives will be discussing prognosis, safety data, and strategies for therapy. This slide summarizes so much of what we know about macroglobulinemia. In the lower left-hand corner, you can see a serum protein electrophoresis with albumin on the left and a very large monoclonal protein on the right. It's larger than albumin, so it's probably about 4 grams per deciliter. In the upper right-hand corner, you can see an immunofixation that shows on the strip albumin on top and a monoclonal protein on the bottom. There's a polyclonal IgG, a very low IgA, both a monoclonal IgM band and kappa band that co-migrate with the electrophoretic band, and low levels of lambda. In the lower right-hand corner, you can see typical lymphoplasmacytic lymphoma morphology, where these cells clearly are not plasma cells, lacking a perinuclear clear zone and peripheral nuclear chromatin, but they're not small lymphocytes either, with abundant blue cytoplasm. And of course, in the upper left-hand corner, you can see retinal hyperviscosity with hemorrhages and tortuosity, typical of macroglobulinemia. When we talk about patients, we have to distinguish those patients who simply have a monoclonal gammopathy, IgM, which actually represents nearly 16 to 20% of monoclonal proteins. These are patients who have a monoclonal protein, but do not have significant marrow infiltration and are completely asymptomatic. Patients with smoldering macroglobulinemia have a monoclonal protein, and it can be either greater than 3 grams, or the bone marrow can have greater than 10% lymphoplasmacytic lymphoma, but it is required that these patients remain asymptomatic. There are patients who have symptomatic Waldenstroms, and these are the patients who have cytopenias due to marrow infiltration, B symptoms due to hepatosplenic and lymph node infiltration, or hyperviscosity due to a large IgM. And then there's the IgM-related disorders, which is IgM-related demyelinating peripheral neuropathy, Muggles neuropathy, or cold agglutinin hemolytic anemia, or type 2 cryoglobulinemia, or IgM amyloidosis, where the symptoms are driven by immunologic properties of the IgM monoclonal protein, but are not related to tumor mass. Of course, with IgM, monoclonal gammopathy, and macroglobulinemia, we have a defining mutation found in almost 95% of patients. That's the MYD88, which is quite useful, not in determining therapy, but useful in terms of confirming the diagnosis of lymphoplasmacytic lymphoma. But it does not distinguish between macroglobulinemia and monoclonal gammopathy of undetermined significance. That remains a clinical distinction. And unfortunately, it also doesn't help distinguish it from splenic marginal zone lymphoma, which has a lot of overlap with macroglobulinemia, although splenic marginal zone has a lower positivity of MYD88, that distinction remains a clinical one. One thing about MYD88 is that it appears to trend for a shorter time for smoldering macroglobulinemia to become active. It didn't reach statistical significance, but MYD88 may predict earlier progression. CXCR4 is the second genetic abnormality found in 30% of patients that have a mutated MYD88. It's never found in wild type MYD88, and it can predict resistance to BTK inhibition, particularly ibrutinib, but also may predict some resistance to bendamustine and bortezomib. An investigational CXCR4 inhibitor, mavorixafor, was investigated, shown to have activity, but was dropped because it was toxic in patients. What about MYD88 and the outcomes in macroglobulinemia? Well, in a chemotherapy-treated cohort, bendamustine, cyclophosphamide, bortezomib, the mutation status did not impact overall survival or time to next treatment. So MYD88 doesn't help you in therapy selection necessarily. It just appears to predict the diagnosis. It's very useful in confirming the diagnosis. Although patients with MYD88 wild type appear to have a higher risk of transformation to large cell lymphoma or myelodysplastic syndrome, therapy-related myeloid neoplasm following therapeutic intervention. And again, emphasizing that MYD88 doesn't predict overall survival, so it's not particularly useful as a prognostic factor either. Please note that the prognosis in macroglobulinemia is excellent, with median survivals well in excess of 10 years. But as I had mentioned 2 slides ago, the risk of transformation to large cell lymphoma in patients was higher if they had MYD88 wild type with an odds ratio of 6, and this was independent of other features. And in fact, the 5-year transformation risk to large cell lymphoma with MYD88 wild type was nearly 16% compared to 3% for MYD88 mutated patients. Therapy-related MDS also is higher in patients who have wild type MYD88, occurring in 8% of patients at a median, and it's quite short, of 30 months. And there were those patients didn't develop AML, but still the MDS became really the major problem, far eclipsing problems associated with the Waldenstrom itself. Now, of course, the question always comes up, why don't we treat everybody at the time of diagnosis? And the important thing to remember is that this is a very, very indolent lymphoma. It cannot be cured, and therefore, early intervention does not result in an improved overall survival. And although the median time to progression is approximately 4 years, and 31% will progress at 2 years, even at 10 years, 20% of patients with smoldering Waldenstrom still haven't developed overt disease. And of course, early intervention may select out for resistant clones, and the treatment of macroglobulinemia carries toxicity in a cohort of patients that we have defined as being completely asymptomatic. And since the survival in these patients often exceeds 10 years, early intervention remains not recommended for these patients, and that these patients should be observed until they become symptomatic, independent of the level of the IgM protein. There's no level such as 3,000 or 5,000 at which we would tell a patient you need treatment based on the IgM level. The consensus recommendations for starting therapy are anemia, thrombocytopenia, symptomatic hyperviscosity, not just an elevated level, progressive demyelinating, moderately severe peripheral neuropathy, Muggles neuropathy, or now it's called DADS, symptomatic type 2 cryoglobulinemia, cold agglutinin hemolytic anemia, or symptomatic autoimmune events attributable to macroglobulin, and the rare IgM forms of AL amyloidosis. If you're not certain, my recommendation would be to do nothing, recheck in 3 months. And again, the IgM level alone does not justify therapy. The staging, and I'll get to 2 staging systems, doesn't count in asymptomatic patients. It's only relevant in active patients that need therapy. So here we have a recently published, this was just published in the last 2 weeks, staging system that's intergroup based on data from Mayo Clinic and Dana-Farber Cancer Institute looking at a staging system for macroglobulinemia. And it was really a very simple staging system. There's only 3 components: the serum albumin greater than or less than 3.5, the LDH, normal or abnormal, and age. But there were 2 strata for ages. Age less than 65, 0 points, 66 to 75, 1 point, greater than 75, 2 points. And so you're looking at the groups who have 0 points, 1 point, 2 point, and 3 points. The important thing to note is that even at 10 years, there's a high proportion of survivors. Secondly, age has a profound impact. Age automatically, if you're over 75, makes you intermediate risk, which is the gray line with a 45% 10-year survival. So 1 staging system, age, LDH, and albumin. Very, very simple. You'll notice that in this staging system, the level of IgM is not part of the model. So the IgM level, 3,000, 5,000, 7,000, was not predictive of overall survival independent of age, albumin, and LDH. The older system, which is about 15 years old, is the International Prognostic Scoring System for Waldenstrom's. That includes 5 parameters: age and hemoglobin, platelet count, beta-2 microglobulin, M protein level. So this one doesn't include LDH or albumin, but does include cytopenias. Age is extremely important. Again, please notice that in this staging system, the IgM level does not become prognostic until the IgM is over 7,000 milligrams per deciliter. So 2 different prognostic systems in existence for macroglobulinemia. I prefer the first one just because it's easy: LDH, age, and albumin. What about hyperviscosity in patients with macroglobulinemia? You should not assume that a high IgM level will translate to hyperviscosity. Over the years, I've treated many patients whose IgM levels were over 6,000 and did not have hyperviscosity. And the rheologic determinants of the IgM are very, very broad. There are patients with IgM levels of 3,500 that have hyperviscosity, people who are 10,000 who don't have hyperviscosity. So you can't look at the IgM level and know without measuring the viscosity. And the only thing that predicts hyperviscosity syndrome, symptomatic hyperviscosity, is the serum viscosity at the time of diagnosis. And viscosity will not predict survival in this disease. And here is the data for predictors of symptomatic hyperviscosity. Even in patients whose IgM was over 6,000 at diagnosis, the median time to hyperviscosity was 6.9 years. But the risk of developing hyperviscosity, if at presentation your viscosity was abnormal, which is greater than 1.8, which is the normal viscosity level of serum, water being 1.0, was the only thing that predicted future hyperviscosity. But survival, as you can see, not different across viscosity groups. So again, the only predictor of viscosity syndrome is an elevated viscosity at diagnosis, but many years to develop. One thing to be aware of is Waldenstrom's and the kidney. This would be a monoclonal gammopathy of renal significance. Renal involvement is 5% of patients. The most common renal lesion in patients with macroglobulinemia is IgM amyloid, followed by cryoglobulinemia. But there is a proportion of patients where you can get direct lymphomatous infiltration of the kidney, where the kidney biopsy shows infiltration with lymphoplasmacytic lymphoma. So just to be aware that there is a renal component occasionally in macroglobulinemia, manifest by proteinuria, which would be cryoglobulinemia, and amyloidosis, hypertension, and fluid retention. Now, this is just a slide looking at causes of death, and it's just important to recognize that over the age of 75, Waldenstrom's itself is only responsible for death in 1/3 of patients. The risk of death after the age of 75 is much greater from non-Waldenstrom's causes, approaching 50% of patients. And so it's important that most patients will die with Waldenstrom's, not of Waldenstrom's. At age 65 to 74, the risk of death from Waldenstrom's is identical to the risk of death from other causes. So as many people will die of non-malignant causes than of macroglobulinemia itself. And it's only in patients under age 65 where the risk of death from Waldenstrom's exceeds the risk of death from other causes. And you need to keep this in mind when you're thinking about therapy and the intensity of therapy and how many drugs you want to use in therapy, if you recognize that many patients will succumb to causes completely unrelated to Waldenstrom's. Keep in mind that rituximab as a single agent can cause a rapid rise in the IgM level and occasionally can actually precipitate hyperviscosity syndrome. So this is a relevant consideration in patients receiving rituximab as a single agent, not that I recommend it. Typically now, when we see patients with very high levels of IgM, we'll often delay the introduction of rituximab until after the first cycle of chemotherapy is completed. So if they're receiving cyclophosphamide, bendamustine, bortezomib, we won't give rituximab with cycle 1, so we don't have to worry about rituximab flare and the need for plasma exchange when we start treatment. It's been over 10 years since bendamustine rituximab became the standard of care for first-line treatment. This comes from a trial from the East German Lymphoma Study Group that compared bendamustine with R-CHOP. 41 patients with Waldenstrom's were treated, 22 in the bendamustine arm, 19 in the R-CHOP arm. Response rates were nearly identical in both groups, so cyclophosphamide is a reasonable first-line choice. But progression-free survival was better for bendamustine, and at the time that this was reported, the relapse rate was much greater in the R-CHOP compared to the bendamustine group. In terms of how do we assess response in Waldenstrom, it's very similar to the multiple myeloma response. Complete response, which is rarely seen in macroglobulinemia, of course, is immunofixation negative serum and urine and a morphologically normal bone marrow aspirator biopsy. VGPR, a 90% reduction in IgM level from diagnosis. PR, a 50 to 90% reduction, and reduction in any extramedullary disease, and a minor response, a 25 to 50%. And then the overall response rate would be a minor response or greater than 25%. And of course, remember that since rituximab can raise the IgM level after the first cycle, don't be fooled thinking that an immediate rise in IgM is progression. It may represent IgM flare. I mentioned those response depths, but it's not very clear that response depth predicts survival in myeloma. This is completely different from patients with multiple myeloma, where patients who achieve a complete response or MRD negativity have longer survivals than patients who achieve less deep responses. In macroglobulinemia, probably because of competing risks of death, response depth does not consistently translate to overall survival, which is why in patients with Waldenstrom's, patients who achieve a minor response, let's say the IgM went from 6,000 to 4,000 or 5,000 to 3,000, which isn't even a PR, those patients can still do very, very well. And in one published report, progression-free survival predicted overall survival, but response depth did not predict overall survival. And so PFS is important, but depth of response does not translate to PFS or OS. What about the duration of response? This, of course, is from Mayo Clinic data, and you can see that the progression-free survival in treatment-naive patients is 3 years. In relapsed refractory patients, it's 2 years with cyclophosphamide-based therapy, better with bendamustine-based therapy. If we look at time to next therapy, it isn't even reached because patients can have biochemical progression of their Waldenstrom and still not require therapy. We'll see patients who respond, IgM falls to 1,000, will raise to 2,000, still not need treatment. They have progressed objectively, but they still don't need intervention because they haven't developed symptoms or cytopenias. What are the clinically relevant endpoints based on the treatment regimen as we try to compare across different treatments? And here I'm looking at bendamustine, cyclophosphamide, and bortezomib. And you can see that in our hands, bendamustine has a higher overall response rate than cyclophosphamide bortezomib. The major response rate is greater for bendamustine. The event-free survival looks longer in bendamustine, as does the progression-free survival, as well as response duration. However, with all of those parameters, the 4-year overall survival is not superior for bendamustine-based therapy. And so if you're looking at overall survival, bendamustine, cyclophosphamide, and bortezomib-based therapies all provide excellent outcomes. This is just a waterfall plot, again, looking at response depth, comparing bendamustine, cyclophosphamide, and bortezomib. And again, what this demonstrates is that bendamustine did better in terms of response depth. You'll notice red and dark blue in the bendamustine representing CR and VGPR, which we're not seeing in cyclophosphamide and bortezomib treated patients. But again, overall survival not superior, and MYD88 mutation did not affect outcome with any of these regimens. Toxicity is quite similar, although nausea and vomiting is higher with cyclophosphamide. But most importantly, it was bortezomib-induced peripheral neuropathy, which was significantly higher in Waldenstrom's patients than what we see in patients with multiple myeloma. And because of the peripheral neuropathy and the long-term survival of these patients, at least at the Mayo practice, bortezomib is not considered a first-line therapy for macroglobulinemia. What about rituximab maintenance therapy in patients with macroglobulinemia? Again, this is based on an East German lymphoma study group. And a couple of things that I want to point out. First of all, the progression-free survival following bendamustine in the East German lymphoma study group is nearly 7 years. That's the first piece. The second piece is that when we looked at the endpoints of probability of progression, rituximab maintenance did not improve outcome in Waldenstrom macroglobulinemia. And as a consequence, we do not recommend rituximab maintenance after the completion of 4 to 6 cycles of bendamustine in macroglobulinemia of Waldenstrom's. This is just a summary slide of proteasome inhibitors that are used, and that includes bortezomib, it includes carfilzomib, which is the next to the last line, ixazomib, the oral proteasome inhibitor, the bottom line, and it also compares BCR, which is line number 4, bortezomib with rituximab and cyclophosphamide, and compares it with FCR, which isn't used anymore due to the hematologic toxicity and immunosuppression. And what you can see is that with all proteasome inhibitors, response rates are very high, over 80% in patients with a PR or greater rate ranging anywhere from 50 to 90%, with progression-free survival median nearly 5 years and very high overall survivals. So proteasome inhibitor therapy, reasonable, but again, the neurotoxicity is an issue. So let me summarize non-BTK inhibitor-based primary therapy. And what I would say is that when we're looking at overall survival, there really doesn't appear to be much of a difference between bendamustine, cyclophosphamide, and bortezomib. But I would point out that all chemoimmunotherapy regimens are superior to rituximab alone. Single agent rituximab really produces inferior response rates in symptomatic Waldenstrom's, and the use of single agent rituximab cannot be recommended. So now we'll move to BTK inhibitors. Of course, when ibrutinib was first introduced, it was looked at in the relapsed refractory setting, median 2 prior therapies, and you can see that the response rate was 62%, and the PR rate was over 50%, and VGPR, which isn't very common with BTK inhibition, was approximately 11%. The intended therapy was 420 milligrams, but as I'll show you later, there are plenty of patients who need dose reduction, but it doesn't compromise their response rate. So intolerance at 420 is not really a problem. You can reduce the ibrutinib dose to 280 and even 140 and still do well. Responses with BTK inhibition is fast. Median time 4 weeks, with a reduction of IgM median from 3,600 to 1,300, and an improvement in hemoglobin from 10.5 to 12.6. But as I will show you, the toxicity associated with ibrutinib, the diarrhea, the bruising and bleeding, and the atrial fibrillation is a real problem with this drug. The second trial was ibrutinib for newly diagnosed macroglobulinemia. The major response rate was 80%, which is actually a little bit lower than bendamustine. And in this small trial, no difference between wild type or mutated CXCR4, but a lower response rate if you were wild type MYD88. A few practical considerations for the use of ibrutinib. It is useful to know the MYD88 status because the response rate will be lower for wild type. There's extensive interaction with cytochrome metabolized drugs. So talking to a pharmacist and reviewing the medication is important. You have to watch these patients for major bleeding, including major GI bleeding. I've certainly seen near exsanguinating hemorrhages from the GI tract with ibrutinib, and we wouldn't recommend it with anticoagulants. And of course, you're thinking anticoagulants if they have atrial fibrillation, so some caution there. We won't use it with non-steroidals, oranges, grapefruit, star fruit, and fish oil because of the CYP3A interaction. The drug should be discontinued before major and minor surgery because of the bleeding risk. There's a significant risk of hypertension that needs to be considered and a very significant risk of atrial fibrillation. In addition, today, ibrutinib as a single agent is not designed for time-limited therapy. It's designed to be continued until progression. And even when ibrutinib is held for surgery, you could see substantial rapid increases in IgM and drops in hemoglobin if ibrutinib is held transiently. One of the approval trials in the FDA was a direct comparison of ibrutinib rituximab to placebo rituximab, showing superiority for the ibrutinib rituximab arm, causing much deeper reductions in the IgM and a much higher CR and VGPR rate. Please keep in mind that this does not prove that ibrutinib rituximab is better than ibrutinib alone. That trial wasn't done, but there's no question that it's better than rituximab alone. But as I've emphasized earlier, single agent rituximab is not a very good treatment for macroglobulinemia. BTK inhibitors of all type, however, are very effective for central nervous system Waldenstrom because BTK inhibitors cross the blood-brain barrier where cyclophosphamide, bortezomib, and bendamustine very limited. And there's no real series here, but multiple case reports of significant benefit of ibrutinib for central nervous system macroglobulinemia with resolution in 18%, improvement in 68%, 14% no benefit. So in patients who have central nervous system lymphomatous meningitis or lymphoplasmacytic lymphoma mass in the brain, a BTK inhibitor is mandatory. Of course, ibrutinib is not the only BTK inhibitor. Acalabrutinib is highly active in macroglobulinemia, producing an overall response rate of 93%, both for treatment naive and relapsed refractory, major response rates in the high 70s, low VGPR rates as expected for all BTK inhibitors, and excellent 2-year progression-free and overall survival, both in treatment naive and relapsed refractory. Toxicity of acalabrutinib is not trivial. Diarrhea remains a problem. Nausea can be a problem as well. Again, the dose of acalabrutinib is 100 milligrams twice a day. But one thing that was important was that atrial fibrillation was much, much lower compared to ibrutinib. Hematologic toxicity is manageable with dose modification, and serious bleeding was seen in 3%. These are the Kaplan-Meier curves for acalabrutinib, showing that both in treatment-naive and relapsed refractory patients, response duration, progression-free survival, and overall survival out to 40 months is really quite good. But the preferred treatment at Mayo Clinic is zanubrutinib, and it was based on this trial that did a head-to-head comparison of ibrutinib and zanubrutinib. And the reason we prefer zanubrutinib was not efficacy. Efficacy, as I will show you, is comparable. But what we did see was that with zanubrutinib, major hemorrhage was less, diarrhea was reduced by 1/3, but most importantly, atrial fibrillation was reduced from 18% in the ibrutinib group to 3% in the zanubrutinib group. And of course, people will tell you that it's easy to control atrial fibrillation, but realistically, if your patient develops atrial fibrillation, a lot of decisions need to be made. Do they need rate control? Do they need to be hospitalized for rate control? Are you going to anticoagulate them for atrial fibrillation, knowing the major hemorrhage risk associated with ibrutinib? Do you have to refer them to cardiology? And are they going to end up with cardioversion or atrial ablation? So the consequences of atrial fibrillation are quite profound. And when I saw that atrial fibrillation was reduced from 18 to 3%, that is strongly compelling reason to consider zanubrutinib over ibrutinib. Now, if you look at the efficacy endpoints, quite frankly, there isn't much difference between ibrutinib and zanubrutinib. The major response rates were comparable, both in two different cutoffs. Now, the VGPR rate was a bit higher in patients who received zanubrutinib, 30% versus 18%, but I am unable to demonstrate to you that the higher VGPR rate means improved survival, either progression-free survival or overall survival. So efficacy comparable, but toxicity much less. And as you can see here, the progression-free survival wasn't different despite the higher VGPR rate here of 36% versus 25% overall. So again, we're using zanubrutinib preferentially simply because of the superior toxicity profile, non-hematologic toxicity. This is just a Kaplan-Meier failure curve that's comparing zanubrutinib to ibrutinib. As you can see on the far left, risk of atrial fibrillation flutter up to 5 years, the prevalence of hypertension, and the prevalence of diarrhea. And I should mention that the diarrhea is not something that is simply diphenoxylate and atropine. These are patients who get severe diarrhea that leads to incontinence, social isolation. They can't leave the house because they get explosive diarrhea. So it's not minimal. These three toxicities become major issues to deal with in an ibrutinib-treated population. So here we have a summary of BTK inhibitors for macroglobulinemia. And you can see that zanubrutinib, ibrutinib, acalabrutinib, and tirabrutinib all produce response rates of 90% or higher, VGPR rates anywhere from 10 to 30%, and outstanding progression-free survivals at 2 years. Pirtobrutinib, unlike the other BTK inhibitors, which are covalent inhibitors of BTK, may work where a prior BTK fails because it's a non-covalent BTK inhibitor. And it's being explored in the treatment of BTK failures with macroglobulinemia. And you can see in this, even in patients with prior covalent BTK inhibition, the overall response rate was 64%, and 83% of those patients were still responsive at 6 months. So the final word, of course, hasn't been written on BTK inhibition, and will be the relative merits of the non-covalent, which right now is ibrutinib, acalabrutinib, zanubrutinib, versus covalent inhibitors, pirtobrutinib. This is a retrospective comparison that was published at ASCO last year, comparing the progression-free and overall survival of bendamustine versus ibrutinib. And I show you this again to emphasize the fact that bendamustine and ibrutinib were identical in terms of progression-free and overall survival. Yes, BR turned out to have a higher complete response rate and a comparable progression-free and overall survival. So the choice of what to use is based on toxicity It's based on whether patients prefer an oral regimen. It's based on whether they would like to have time-limited therapy, which would be bendamustine 4 to 6 months, or whether indefinite ongoing maintenance therapy with ibrutinib. Recently published was bendamustine with bortezomib, second-line therapy. So we combined a proteasome inhibitor with bendamustine. I would note that the bortezomib was given in standard fashion, sub-Q once a week. The overall response rate was 82%. I don't know that that is actually better than bendamustine alone. Progression-free survival at 18 months was 84% and was 79% at 30 months. I will tell you that this triplet combination has not changed my practice because I am unclear that the addition of bortezomib really made a much greater benefit in terms of progression-free survival and overall response compared to bendamustine alone. Venetoclax is extremely active in relapsed refractory myeloma. The weekly ramp-up is identical to what you use for low-risk MDS and elderly patients with acute leukemia, 200 to 400 to 800, although in my practice, most of my patients cannot tolerate 800 milligrams, and the MTD is 400 milligrams. But venetoclax in relapsed refractory disease produced an overall response rate of 87% with pretty manageable toxicity, anemia, neutropenia, constipation, diarrhea. So venetoclax has to be kept in mind as high activity for second-line therapy in macroglobulinemia. This is a retrospective study of venetoclax in previously treated Waldenstrom, and you can see that the overall response rate was nearly 84% with very, very good durability. You can see progression-free survival was about 3 years with no difference between CXCR4 mutation. So again, venetoclax is active. Now, this was just published in Blood 3 months ago. And this was a combination of ibrutinib and venetoclax as initial therapy for newly diagnosed macroglobulinemia, resulting in an overall response rate of 95% and a 24-month progression-free survival of over 50%. But this trial was terminated early because there were 4 deaths out of 45 participants, or 2 deaths out of 45, which in Waldenstrom's is a lot, with 4 patients having high-grade ventricular arrhythmias. And so, yes, it's active, but automatically combining it without looking at toxicity is not recommended. And the reason why this trial was considered exciting is because this was intended as time-limited therapy, not indefinite therapy, but ventricular arrhythmias in 9%. So I'm going to summarize so we can go to questions. In newly diagnosed macroglobulinemia, of course, if patients are asymptomatic, IgM, MGUS, observation, I don't care what the IgM level is. Rituximab as a single agent is not recommended unless patients have MGUS neuropathy, cold agglutinin hemolytic anemia, or type 2 cryoglobulin. For patients that are symptomatic and need therapy, you have a choice. Either bendamustine 4 to 6 cycles without rituximab maintenance, or our recommended BTK inhibitor zanubrutinib. And that really depends on patient preference. When you relapse, if the patient had a response of greater than 3 to 4 years, you may re-administer the exact same treatment. So if you gave cyclophosphamide, they relapse 40 months later, you can re-offer them cyclophosphamide if they tolerated it well without a lot of toxicity. At first relapse, our recommendation would be that if they relapsed on treatment, such as ibrutinib, then you'd give R-bendamustine. If you relapse off therapy, our recommendation would be to repeat the same treatment. If you relapsed on R-bendamustine, we would then recommend zanubrutinib. And then for later relapse, it's very, very complicated because there's so many options. But if you have received both R-bendamustine and ibrutinib or zanubrutinib, options would include venetoclax, pirtobrutinib, which of course is a non-covalent BTK inhibitor and will be active when covalent BTK inhibitors, bortezomib, stem cell transplant in selected patients, and then repeat a previously used therapy if the response duration was greater than 3 years. And with that, a few key takeaways, and I'll turn over to questions. Again, therapy is never based on the IgM level. If you're not sure, it's better just to monitor. High IgM level will not justify therapy. Staging is relevant only in patients with active macroglobulinemia. Just a little bit, because we have so many people involved in the macroglobulinemia clinic at Mayo, for which so much of this wouldn't have been possible. And I'll turn it over to you. You've got my email if you have further questions, and you also have the my Twitter. And with that, I'm going to stop sharing and turn things back over to Dr. Agarwal and Dr. Khurana. Thank you for your attention.
Thank you, sir, for that fantastic talk. Always worth to listen to you. That was lovely, sir. We had a great learning, sir. Thank you so much. And I now request all our discussants to please put the raise hand signs so that we can start our question answer session with Dr. Mori. No raise hand signs. Till the raise hand signs to appear, sir. Sir, I have a question for you, sir. Is there any treatment difference in those patients who are MYD88 mutation positive as well as CXCR4 mutation both positive? So there is a difference of treatment to start with, if both positive, only one positive, or one of the two.
So it depends. If you're using chemoimmunotherapy, it doesn't make any difference at all. Neither MYD88 or CXCR4 are predictive. But patients who have a wild type MYD88, a wild type MYD88 have a significantly lower response rate to BTK inhibitors, and patients that are mutated MYD88 and mutated CXCR4 also have substantially lower response rates to BTK inhibitors.
Thank you, sir. One question from the audience, Dr. Thomas Kunchere wants to know, what is the duration of treatment with venetoclax in Waldenstrom Macroglobulinemia?
So that's a great question, and I don't think that's very well defined yet. Typically, if the patient is first relapse, I'll normally treat them for about 6 months and stop and then observe. But, that's not based on very high-grade evidence, but it's so easy to monitor and the disease is so indolent, it's certainly reasonable that if you start to see progression, to resume it. But typically, 6 months would be a reasonable course of treatment with venetoclax as a single agent.
Thank you, sir. Dr. Yogalakshmi, your question, please.
Thank you, sir, for this excellent lecture. And I thank Agarwal sir also for giving me this opportunity. Actually, we had one patient of Waldenstrom Macroglobulinemia who was treated 3 years back with bendamustine and rituximab. And now, after 3 years, patient is having symptomatic anemia requiring frequent transfusions. And now the IgM level is elevated to 5 gram per deciliter. But she is not having any bone marrow is normal, and there are small nodes which are on biopsy have turned out to be reactive nodes. So shall we treat this patient? There is no other cause of anemia. So shall we treat this patient as a relapsed disease?
you want to be sure that you've done genetics looking for MDS. I mean, the patient's been exposed to an alkylating-like agent, and the patient, and you worry about secondary or therapy-related myeloid neoplasm. There's a bit of a disconnect here that I'm not clear on, because you've got a rising IgM level, yet the bone marrow is not showing significant lymphoplasmacytic lymphoma. I mean, the mechanism of anemia in macroglobulinemia is direct infiltration. And typically a transfusion-dependent anemia, you normally need 50, 60% infiltration. 20%, 25% infiltration is not going to do it. And so if metaphase cytogenetics weren't done, iron stains for ring sideroblasts, I'd worry about a therapy-related myeloid neoplasm. How high is the IgM now?
5 grams, sir.
Oh, that's pretty high. Then you have to, of course, worry about the possibility of a geographic miss with the bone marrow, because that IgM of 5,000 has got to be coming from someplace. And even if you didn't find it in the bone marrow, 5,000 normally takes a lot of lymphoplasmacytic mass. Under those circumstances, if there's nothing to suggest morphologically MDS, yeah, I'd probably retreat her. Symptomatic transfusion-dependent anemia, that would have me concerned with an IgM of 5,000 that it is relapsed disease.
Thank you, sir. Sir, I have one more question. If we are starting acalabrutinib for a patient on relapsed refractory Waldenstrom Macroglobulinemia, how long should we wait for the response to occur?
Oh, responses with BTK inhibitors are pretty fast. So you ought to see the IgM reduced by 4 weeks, and you ought to actually see a response by 8. It's pretty quick.
Okay, sir. Thank you.
Thank you. Sir, you have another question?
No.
Okay, so when the chat box doesn't show any more question. So, oh, Dr. Thamodika, your question. Please go ahead, sir.
Yes, so thank you, Dr. Gertz, for that wonderful lecture. My question is, if there are no treatment indications in a patient, only the IgM paraprotein, would you do the bone marrow biopsy at that point, or would you wait until there are treatment indications?
Yeah. So some of it's a discussion with the patient. I mean, some patients get freaked out, if we don't do anything. But in my practice, if someone's got an IgM 3,500, hemoglobin is 14, and no neuropathy and no palpable nodes on examination, I'm not doing a bone marrow, because there's nothing in the bone marrow that I'm going to find that says I need to treat you because you're not symptomatic. So I'd be happy to not do a bone marrow.
All right. Thank you.
Thank you. So I think there are no more questions from the audience, and I think there are no more raise hand signs also.
Thank you, Mr. Sumit.
Yeah, thank you so much, sir. Again,
My pleasure. Have a wonderful evening.
thank you so much, sir.
All right, take care now.
Request,
Bye-bye.
Mr. Sumit.
I now request Sumit Madan to please go for final vote of thanks.
There's a question now.
Okay, sir, just a minute. Is there any question? Yeah. Dr. E. Montant, your question, please.
Sir, thank you for the excellent job. May I know the safe level of IgM booster rituximab? Safe level or IgM level?
All levels of IgM are safe. I mean, viscosity is a clinical syndrome that can occur with low levels, but I've monitored patients with 8,000 and 10,000 IgMs without hyperviscosity. And so, I mean, you can't know what the safe level is. If you have a very high level, you're obligated to measure the serum viscosity level to know if the patient is at risk. Now, one thing I will always do if the IgM level is over 5,000, I always have them see an ophthalmologist. I need an ophthalmologist to look in those eye grounds and tell me that there's no retinal hemorrhage, because I can't do a very good retinal exam in the office, because you really need to be dilated. And you don't want to wait till they're saying, I have visual loss. And so with a high IgM, I'm always having them see the ophthalmologist. And if it's over 5,000, I'll have them see the ophthalmologist every 6 months, just to be sure. They need to tell me that no retinal hemorrhages.
Thank you, sir. Second, is any experience or acquired von Willebrand disease in Waldenstrom, sir?
Yeah, so that's a very real problem. Patients do develop acquired von Willebrand's disease. It's due to direct inhibition of von Willebrand factor by the IgM. It's seen in about 3% of patients, and it is an indication for treatment. Successful treatment eliminates the von Willebrand's disease, but frankly, it's pretty easy to diagnose because you'll see the prolongation of the APTT, and once you see the APTT prolongation, usually with the normal prothrombin time and fibrinogen, then factor analysis will lead you to the correct diagnosis. It is an indication for treatment because those patients can have serious hemorrhage.
Yes, sir. How to handle antiplatelet, especially with proteasome inhibitor? Yes.
So the question
Antiplatelet,
is how,
yes, antiplatelet and acquired von Willebrand and PI therapy.
yeah, I must admit, I haven't used PIs much in patients with the inhibitor. Mostly for the inhibitor, I'm using either BTK or R-bendamustine. So I don't have any firsthand experience to elaborate on your question. Sorry.
Yes. Thank you so much, sir. Yeah.
Thank you, Dr. Emoted. Dr. Thanda, your question.
Thank you very much for your excellent lecture, sir. We had a patient who is 80 years old, and he
I'm
presented with
sorry, I can't hear. You're not loud enough. Maybe my colleagues can hear better.
Can you please be loud, Dr. Thanda?
Hello.
Yeah. Yes, now.
Can you hear me? Yes. We had a patient, 80 years old man, who presented with the hyperviscosity syndrome, and we treated him first with the R-CHOP, and he lost follow-up and present with the relapse symptom, and so we gave him then ER. But when we gave him, and he needs plasmapheresis also for his hyperviscosity syndrome. So, and this time he is refractory to Pendamis ER treatment. So, in such patient and in a resource limited setting like our country, so what kind of therapy would you like to suggest for him?
Sure. What was the manifestation, the clinical manifestation of hyperviscosity?
The digital thrombosis, sir.
Okay, so that could be, you want to check that patient for cryoglobulins as well with digital thrombosis. But if you don't have access to BTK inhibition, this would be a place where you would either use fludarabine, which should be available, or bortezomib. Either one of those would be acceptable. An 80-year-old man, probably reduce the fludarabine by 40%, give them 3 days out of 5 instead of 5 days out of 5. But 30 per meter squared, 25 per meter squared for 3 days, fludarabine would do it. Bortezomib weekly would do it if the duration of response to the original R-CHOP was less than 3 years.
Oh, thank you so much, sir. And another question is the dose of ibrutinib in the Waldenstrom. I'd like to know the dose of ibrutinib in Waldenstrom.
Well, the normal dose is 420, but there's a lot of people who don't tolerate that due to hematologic toxicity or diarrhea. And if you cut the dose from 420 to 280, a lot of these patients do absolutely fine. So 420 is kind of an MTD, but older patients can tolerate lower doses of ibrutinib.
Thank you, sir.
Thank you, Dr. Thanda. Any other discussion? Want to ask any other question? Well, so I think now there are no more raising signs, and
All right.
and no more chat questions in the chat box. Thank you so much once again, sir. And
Until next time, take care.
And I hand over to to Mr. Sumit Madan for the final quote of thanks. Mr. Sumit.
Okay, he's probably not there. Okay.
Okay.
Right.
Thank you so much, sir.
Thank you.
Thank
Bye-bye.
you.
Good night, everybody.
Thank you.
Thank
Good
you.
night.
Bye.